The American Society of Anesthesiologists and the European Society of Anesthesiology do not support routine, universal preoperative electrolyte screening. Yet, preoperative dysnatremia occurs in up to 10% of surgical patients, and dyskalemia in up to 5%. Even at borderline values, these abnormalities are strict, independent predictors of 30-day perioperative mortality and major morbidity. Ordering indiscriminate chemistry panels on every healthy patient generates administrative noise. It yields false positives that trigger delays and distracts the clinical team from actual physiological threats. Preoperative biochemical scrutiny must transition away from an automatic administrative checklist and become a rigorously targeted diagnostic intervention. We restrict testing to specific markers of frailty and high-risk pharmacological profiles, specifically evaluating medications taken within 30 days of elective surgery. This screening matrix establishes mandatory testing criteria: patients over 65, ASA 3 or higher, or eGFR below 60. We strictly evaluate high-risk medications: thiazides, loop diuretics, ACE inhibitors, and MRAs. We must also screen SGLT2 inhibitors, chronic PPIs, and nephrotoxic oncology agents like cisplatin. When a patient meets any of these targeted criteria, the standard preoperative panel must explicitly measure sodium, potassium, chloride, bicarbonate, urea, creatinine, and glucose. By aligning testing directly with the patient's specific physiology and pharmacology, clinicians eliminate diagnostic waste and target the specific morbidities most likely to cause perioperative collapse. Clinicians frequently react to a single out-of-range laboratory value by reflexively canceling an elective procedure. The decision to proceed or defer is governed by acuity, symptom severity, and surgical urgency. Acuity and symptoms reveal the threat level. Rapid shifts are lethal, while chronic derangements are compensated. Finally, surgical urgency dictates whether to immediately correct or stabilize. Physiological stability and the trajectory of the disease dictate the perioperative timeline. The isolated number on the hematology report does not. There are, however, 5 physiological derangements that bypass the triad entirely. These danger zone syndromes are absolute clinical emergencies that mandate immediate, protocol-driven medical intervention. Looking at panel 1, the first of these is severe symptomatic hyponatremia. This is triggered when serum sodium drops below 120 millimoles per liter and the patient presents with seizures, coma, or profound cardiorespiratory distress. The algorithmic response requires rapid neurological rescue. Administer 150 milliliters of 3% hypertonic saline over 20 minutes to halt cerebral edema. But correcting sodium too rapidly strips water from brain tissue, inducing osmotic demyelination syndrome. You must strictly cap correction at 10 millimoles per 24 hours. Acute symptomatic dysnatremia demands precise, volume-controlled intervention. It overrides any pre-existing surgical schedule. Hyperkalemia directly disrupts the delicate cardiac action potential, driving lethal ventricular arrhythmias that rapidly and predictably progress to complete asystole. The second danger zone is the hyperkalemic threat. Intervention is required at a potassium level of 6.5 millimoles per liter, or at any potassium level that demonstrates an ECG change. The algorithm begins with membrane stabilization. 10% calcium gluconate prevents cardiac arrest, but doesn't lower potassium. Step 2 executes a cellular shift, using insulin and dextrose to drive potassium into tissues. Critically, this induces severe hypoglycemia, the single greatest iatrogenic harm. This mandates a strict clinical protocol. Blood glucose must be monitored hourly for 6 hours following any insulin dextrose administration. Attempting to correct an electrophysiological crisis reliably creates a secondary metabolic crisis if the clinician fails to anticipate the pharmacological fallout. We must also address the intertwined cardiovascular and neuromuscular threats posed by divalent cation depletion in the perioperative environment. The third danger zone is an ionized calcium emergency, triggering life-threatening laryngospasm or refractory hypotension. The fourth is torsades-prone hypomagnesemia. Magnesium below 1.0 with QT prolongation mandates immediate intravenous magnesium sulfate to prevent sudden cardiac death. Because general anesthesia masks the physical symptoms of tetany and cardiovascular depression, failing to identify and replete these cations guarantees severe complications upon emergence. The most insidious danger zone targets highly malnourished or cachectic oncological patients awaiting enteral nutrition or TPN. This is refeeding syndrome. The sudden reintroduction of carbohydrates triggers a massive insulin surge. This surge aggressively drives glucose, along with remaining extracellular electrolytes, into the depleted intracellular spaces. The hallmark consequence of this shift is severe hypophosphatemia. The resulting lack of ATP critically impairs diaphragmatic function, leading directly to a failure to wean the patient from mechanical ventilation. The mandatory prophylactic protocol requires intravenous thiamine administration at least 30 minutes prior to caloric introduction to serve as a vital cofactor and prevent collapse. Surgical success is entirely undermined if the postoperative nutritional strategy induces a multi-system biochemical failure. Treating these 5 danger zones as completely isolated phenomena ignores the interdependent architecture of human cellular ion channels. On the left, magnesium blocks the ROM-K channel, Depletion disinhibits it, causing continuous renal potassium wasting. IV replacement is futile until magnesium is restored. On the right, hypomagnesemia suppresses parathyroid hormone, causing target organ resistance. Calcium correction remains incomplete without concurrent magnesium repletion. The ultimate clinical directive for the perioperative physician is strict hierarchy. You must always check, verify, and replete magnesium stores prior to, or concurrently with, treating potassium and calcium derangements to prevent iatrogenic failure.